Thank you, Mr. Chairman. Good afternoon, everyone. So now we'll talk about the management of nocturia. So let's start by asking who really suffers from nocturia. It affects actually all ages, and it increases with age. So people above 50 years old, 50% of them will complain of nocturia. Nocturia actually occurs in both sexes. Traditionally, the prostate is blamed, and nocturia is not considered a female problem, but it is common in women as well as men. So nocturia is a highly prevalent but underreported condition. So who of you usually see or face nocturia patients? Do you have this kind of patients in your clinics? Okay, so maybe you'll have the same reaction as we have when you meet this patient and you ask him or her, do you wake up during sleep to void? You either have one of two very famous reactions. The first one is that the patient will directly say, no, I don't go. But then he starts to say, I'm okay, I'm good, but I go because I have diabetes mellitus, I go because I drink liquids, I do this when I drink by night, or I think it's normal for my age. So the patient starts to give reasons, but he never say, yes, I go. Or on the other hand, they will say, I go many times, doctor. Doctor, I live in the toilet. I don't leave the toilet because I keep going all the night, or I don't sleep. So the patients are usually exaggerating this, and you need to find out really what is going on with them. So the thorough history is very important. We have, according to the ICS report on terminology of nocturia, and I said this yesterday, that we have 3 definitions that are changing now. First one was the complaint that the individual has to wake at night 1 or more times. And in 2010, that was the complaint of interruption of sleep 1 or more times because of the need to micturate, and each void has to be preceded and followed by sleep. And this was the main importance in the definition, that the patient has to be sleeping and the voiding, awaking him or her up, and then he has to sleep again. So if you go to bed and you didn't sleep, you keep reading or watching the TV and you went to bed, to toilet, this is not nocturia. Then lately, it says the number of times urine is passed during the main sleep period, having woken to pass urine for the first time. Each urination must be followed by sleep or the intention to sleep. And this should be qualified using a bladder diary, and this is now the formal definition of nocturia by the ICS. Nocturnal polyuria is characterized by overproduction of urine at night. It should be greater than 20 to 33% of total 24-hour urine production or volume, and this depends on age. Nocturnal polyuria is a major contributing factor in most nocturia cases. So the measurement should include all urine produced after going to bed and the first void after arising. There are many contributing causes for nocturia, because nocturia per se is like, it's a symptom, but there are many things that lead to nocturia, mainly, of course, the nocturnal polyuria. So nocturia may be present as part of other conditions, which may or may not be directly related to the urinary tract, for example, heart failure or sleep apnea. Therefore, patients will definitely consult not only you as urologist, but also others like gynecologists, geriatricians, neurologists, sleep experts, endocrinologists, cardiologists, immunologists, rheumatologists, and or general practitioners. So it's a big issue, and sometimes the patient keep going from one specialty to the other to find out what is wrong with him. And you as a urologist, even if you have patients complaining of nocturia and you have nothing to do, has nothing to do with urinary tract, you will then advise him to find out what is wrong with his other systems. We recently published the ICS consensus on the diagnosis and treatment of nocturia. And we had a lot of things about the diagnosis and treatment. And there is diagnostic and therapeutic pathways for nocturia patients based on the underlying causes of nocturia. So you can see that there are many causes that goes around nocturia, and you need to look at the proper pathway for it. There are several tools available to accurately diagnose the underlying causes of nocturia. First of all, of course, a thorough medical history, the physical examination, disease-specific questionnaires, and they are available from many sources, and of course, the frequency volume chart or bladder diary. So there are many types of voiding diaries, as you know, mainly the bladder diary, and these are example. And we actually in our countries we were able to translate and validate this questionnaire in our language because it is important to have it in your own language to help your patients. So I'm not sure if you already have this in Turkish language. How many days do you need to use the bladder diary? Usually 3 days, otherwise the patients will not be compliant to do. So this is one of the, for example, the examples of voiding diary, and you can see that there is frequency during the daytime, and this from which you can see that the patient has frequency, urgency, and probably an overactive bladder syndrome. While if you look at this, you will see the more exertion of urine during night time, and this definitely, if you calculate the nighttime volumes, this will be more than 30%, and this will denote nocturnal polyuria. So this is how the bladder diary can help you. If the patient can be able to fill it out and give it to you afterwards, you will definitely be able to know how much volume of urine is secreted in the daytime and the nighttime. There are urological factors that may lead to nocturia and require assessment of the function of the urinary tract, including bladder, prostate, and urethra. And this is our role, to rule out any cause within the urinary tract. Nephrological evaluation should assess the patient's renal function profile, as nocturia can be the result of nephrogenic diabetes insipidus, hypercalciuria, or polyuria. And you can also elicit this from the bladder diaries if you have the patient coming to you with excessive amount of fluid intake and urine production, which can denote diabetes insipidus. So this can be also helpful from the bladder diaries. Changes in sex hormone levels in menopausal women and during andropause in men must also be considered, usually due to the impact of the hormone changes on sodium excretion and reabsorption via the renin-angiotensin-aldosterone system, as well as water excretion via the antidiuretic hormone. It has something to do with the change of hormones and the difference between male and female. Patients with sleep apnea should be identified since they present with impaired blood pressure, dipping at nighttime, the natriuresis, associated with increased plasma level of atrial natriureteric peptide, and this will definitely cause more secretion of urine during the sleeping period or during the apnea period. So sleep disorders can be diagnosed clinically or through validated questionnaires also, and this has been to be considered or taken in consideration while treating these patients. Nocturia can also be associated with increase in diuresis following increased volume of the central vascular system, or due to congestive heart failure or lower limb venous insufficiency. So assessment and diagnosis of these conditions are important. Assessment of fluid intake, including fluid and salt, is important during diagnosing these cases. Conditions such as diabetes and obesity, which also increase diuresis or even alter the circadian rhythm of urine production, has to be taken in consideration, and intake diaries and renal function profiles can be used to estimate the dietary intake. Other factors that have been considered in the causation of nocturia and nocturnal polyuria are including abnormality in nocturnal secretion or action of the vasopressin, which describes classical nocturnal polyuria syndrome, any edema forming state, in addition to congestive heart failure, chronic renal disease, nephrotic syndrome, hypoalbuminemia, and liver failure, can be a cause. Comorbidities such as autonomic nervous system dysfunction, Alzheimer's disease, multisystem atrophy, stroke, and Parkinsonism can have a role. If you look at the treatment option, there is no single treatment which can effectively treat nocturia in all contexts. Desmopressin is the only evidence-based pharmaceutical therapy for nocturia and nocturnal polyuria. Patients with nocturia have to face many hurdles before being diagnosed properly and treated with desmopressin instead of treating overactive bladder and BPH, which is the first line for us to treat when we see these patients. So potential reasons limiting the use of desmopressin usually are the expected side effects, the limited knowledge of clinicians regarding the drug and how to use it, and the anxiety about safety, regardless of the evidence that with the available low-dose formulations, hyponatremia is extremely rare, even in older patients. So this has to be revised and reconsidered that the new formulations and doses are much safer than before. Also, we have to look at the lifestyle interventions, which may be useful in some nocturia patients. So there are some lifestyle and behavior modifications, including minimization of fluid intake at least 2 hours before going to bed, especially caffeine and alcohol, of course. Restriction of total fluid consumption to less than 2 liters per day. Emptying the bladder before going to bed. Increasing exercise and fitness levels. Reducing dietary salt intake and weight loss for overweight patients. So these are some of the advices that we need to keep in mind while talking to our patients, that they have to try all these lifestyle modifications even before the medication starts. For patients with peripheral edema and due to congestive heart failure or chronic venous insufficiency, try elevating the legs above heart level for a few hours before going to bed, and this could be of benefit because it eliminates some of the fluids in the lower limbs and the lower part of the body, before sleeping, so the patient can get rid of many of the fluids inside the body. For those on diuretics, these could be taken no later than mid-afternoon, considering the half-life of the specific diuretic, so that the effect is not bothering the patient during the nighttime. Improving nocturnal bladder storage capacity and increase in the volume at which bladder activity is elicited and increased urine production at night is important to help these patients. And as urologists, when we prescribe antimuscarinic agents or alpha blockers for patients with benign prostatic hyperplasia or with overactive bladder, it's proven that this kind of medication definitely improves the symptoms of nocturia for these patients, and there is a decrease in the number of nocturnal voids with using these kinds of treatment. But this is not enough for them, especially for those complaining or having nocturnal polyuria, where the antimuscarinic and alpha blocker will not be enough for them. So for patients who have nocturnal polyuria, treatment with an antidiuretic like desmopressin acetate is warranted to address insufficient secretion of nocturnal vasopressin. Desmopressin acetate is a synthetic analog of vasopressin or antidiuretic hormone, which is a selective vasopressin receptor 2 agonist that induces antidiuresis. Desmopressin mimics the action of vasopressin, decreasing urine production and increasing urine osmolality. According to many studies, desmopressin was associated with a dose-dependent decrease in numbers of nocturnal voids and voided volume. And there are greater proportions of subjects with more than 33% reduction in nocturnal voids and increased duration of the first uninterrupted sleep period. Females were more sensitive to desmopressin than males. And desmopressin also increased the mean time to first nocturnal void by 49 minutes, and this was compared to placebo. What about the side effects of desmopressin? The adverse events or side effects related to the use of desmopressin, OTD, which is oral disintegrated tablet formulation, included nausea, diarrhea, dizziness, and hyponatremia. while those reported for the intranasal spray formulation included nasal-related events, hypertension, and hyponatremia. The safety data from the clinical studies showed desmopressin to have an acceptable safety profile. And hyponatremia is the main safety finding of this agent, so this is what we are concerned with, especially in the older age. Hyponatremia has been reported in pediatric and adult patients before for long time, number of years, when we were using it for nocturia enuresis and other causes of nocturia. And it has been seen mainly in older population with earlier formulation of desmopressin. Other risk factors for desmopressin-induced hyponatremia include the baseline renal dysfunction. We have to be careful of this, the small body mass, and female sex. So with dealing with these patients, we have to be more cautious and more careful, and maybe with closer follow-up. Desmopressin is contraindicated in patients with hyponatremia. Example, those with baseline serum concentration below normal range of 135 millimole. For those eligible for treatment, careful monitoring of serum sodium concentration is necessary. So you need to look and monitor this prior to initiating the treatment. Before starting the treatment, try to monitor the sodium concentration, serum sodium concentration, and within 7 days and at 1 month after initiating or resuming a treatment, and after a dose increment, and then periodically every 6 months thereafter. In patients more than 65 years old, more frequent serum sodium monitoring is recommended to make sure that the patients are still in the safe range. Sex differences to desmopressin treatment have shown that the minimum effective dose was lower for women than for men. So the minimum effective dose for the OTD was 100 microgram in men and 25 microgram in women. And in the study with the intranasal spray formulation, the low dose was associated with a statistically significant reduction from baseline in mean nocturnal voids versus placebo in both men and women. So for the nasal spray, there wasn't much difference between both sexes, but for the OTD, women are more sensitive to the drug than men. So in conclusion, nocturia is a highly prevalent, bothersome medical condition that affects men and women of all ages. It is an important public health issue due to its profound impact on quality of life, work productivity, risk of falls and fractures, and mortality primarily due to sleep interruption. And there are some publication about mortality due to nocturia. Appropriate assessment and diagnosis is imperative for treatment success, and the use of voiding diaries along with comprehensive patient evaluation is crucial to accurately identify the cause of nocturia and thereby tailor an optimal management approach. Nocturnal polyuria, the major causative factor of nocturia, presents in most patients with nocturia and can be effectively managed with desmopressin if accurately diagnosed. So before I finish, I want to invite all of you to our 17th annual meeting of the Pan-Arab Conscience Society in collaboration with the ICS that will be held in Amman, Jordan this year from 6 to 8 of February. So I hope we have many of our Turkish colleagues to come to our meeting. And thank you for your attention.